Welcome back to my series on evaluation and management coding. We've covered history, we've covered examination, and today we're going to cover the star of the show, medical decision making. Decision making should really be on the forefront of your mind when you are thinking about your level of service. And it's true as anything now, because when we look at what's changing in 2021, medical decision making is going to be the almost sole decision of how we select our level of service. History and exams still need to be performed and still need to be documented, but the level of service is going to be selected for office visits, codes 99201 through 99215, based off of just medical decision making in 2021. But let's talk about our current medical decision making process, because it's only going to change for that one component. All of our inpatient visits, skilled nursing facilities, observations, etc., are still going to go by our old medical decision-making process for a good period of time until they can kind of reevaluate and catch that up. So let's take a look at what is current in our medical decision-making thought process and scoring. So there's three key concepts that go into our medical decision making, and essentially it's our diagnoses, the amount of risk, and the data that we're reviewing. That's kind of been tweaked a little bit in the future, but for the most part that's what it is. It's everything that went into that thought process for the provider for that day. How many diagnoses are they trying to manage? Are there counterindications? Are there disease process that they have to look out for? Are there labs, x-rays, any kind of testing that they had to review? And it might even be, is there an exacerbation of their condition, either a mild exacerbation or a severe exacerbation? That makes things a little bit different, the mild versus the severe. So everything that provider has to think about and then get onto paper, we can score for our medical decision making. So medical decision making and medical necessity are not the same thing. I always say they are kind of similar. So medical decision making does help kind of feed into that medical necessity, kind of speak to it. You know, why are we treating this patient? What's going on with them? How much work are we putting into it? But they're not the same. Medical necessity is actually defined by Chapter 12 of the CMS Claims Processing Manual, Section 30.6.1. And it says medical necessity of a service is the overarching criteria for payment. In addition to the individual requirements of a CPT code, it would not be medically necessary or appropriate to bill a higher level of evaluation and management service when a lower level of service is warranted. The volume of documentation should not be the primary influence upon which a specific level of service is billed. Documentation should support the level of service reported. The service should be documented during or as soon as practicable after it is provided in order to maintain an accurate medical record. So what does that mean? It means that if a patient's coming into the office with a minor problem, a splinter, for example, we could bulk up the documentation with a bunch of bloat, a bunch of full history on them, a full examination, and technically we might meet a level 5 service based off of those just documentation requirements. We might meet those, but is it really appropriate? Was it medically necessary to bill a high level of service for a patient that came in with a minor problem? No, because medical necessity is our overarching criteria. So we're selecting the level of service not just based off of what boxes we selected and we're able to check off when we're doing our scorecards, but truly what is the medical need of that patient? So that volume of documentation alone just doesn't always represent necessarily the level of service. So just because you dumped a bunch of crap in there doesn't mean you get to bill a higher level. The other thing I want to make very, very clear about medical decision making is, first off, like I said, it's not medical necessity, and it's also not medical risk. Risk is one of the categories, but when we're scoring out our medical decision making, we only need to hit 2 of the 3 categories. So if we hit for our moderate level in 2 of the categories, we can still code that as a moderate level evaluation and management. So let's kind of look at some things. So the first section is our number of diagnoses or treatment options. So in order to get high, you would need at least 4 points in this area. So they're an additive point series. So the first is our self-limited or minor problems, you get 1 point for. And self-limited or minor means that if the patient hadn't presented for medical care, it would have likely resolved on its own. Something like a cold or an insect bite. Any established problem that is stable or improved, you get 1 point for. Now, there's a difference between new patient and new problem, an established patient and an established problem. If you look at the grid, it says this is new or established to the examiner. So you can have a established patient but have a new problem with that. So if that patient has seen you for 50 years, but they're coming in with a new problem, a URI or a UTI or something, and that's a new problem, even though they're an established patient, the problem is new. And it's to examiner. So for example, a group practice where you've got 10 different practitioners working, if that specific practitioner has not seen that patient for that problem before, that would be a new problem to them. So maybe they've seen one of the other providers 100 times for their diabetes, but if that new examiner, that new provider is seeing that's a new problem to them the first time they are seeing them for their diabetes. If it's an established problem that's worsening, you actually get 2 points. If it is a new problem with no additional workup, you get 3 points, but you can only count for one of those. So even if you have 6 of them, you only get 3 points because there's a maximum of 1 problem for 3 points. So when we talk about additional workup is anything done beyond that patient encounter after the patient leaves to further divulge into that diagnosis. So if they're ordering x-rays and labs and stuff that the patient has to go out and have done, any additional testing to figure out more definitively maybe what the diagnosis is, that's additional workup. If that provider has that result right away by the end of that encounter, it is not additional workup. So think about, especially in urgent care settings, a rapid strep, a rapid flu, urine dip, those are all resulted right away. They don't count as additional workup because that's not done beyond the encounter. That provider has that and is probably separately billing for it as a separate CPT, so that they had the result of right away doesn't count as additional workup. Now, if it's a problem where they are doing additional workup, sending out for, an MRI, an X-ray, an ultrasound, lab work, those are things where you get 4 points. So anytime you're doing those additional workup for a new problem, you're already at the max. You've got the 4 points. That's, anything more than that is icing on the cake, but the max you can get for high level is 4, so you're good to go. The next section is the amount or complexity of data reviewed. Now, my friend over on LinkedIn, Sonal Patel, said that she finds a lot of points for her providers in exam. I found a lot of opportunity for my providers actually in the data reviewed because I think sometimes they're not documenting appropriately to clarify what exactly they're reviewing, or they're just copying and pasting data in and not realizing that it doesn't count. So with the amount of complexity of data reviewed, again, these are points. The maximum points you could get for a high level would be 4. What I mean by the maximum is that the highest level of service you can get for medical decision making is high, which requires 4 or more points. So anything more than 4 is just kind of extras. So if the provider reviews or orders any laboratory testing, that would be 1 point. If they review or order any radiological examinations, it's 1 point. If the provider reviews or orders anything in the medicine section of CPT, it's 1 point. So we've got a lot in the medicine section of CPT. Psychiatry services, dialysis, ophthalmology procedures, cardiovascular monitoring services, echocardiography, non-invasive vascular diagnostic studies, allergy testing, sleep studies, health and behavioral services, photodynamic therapy, special dermatological procedures. Physical therapy is part of the medicine section of CPT, evaluations for physical therapy. Discussion of test results with the performing physician is 1 point. You get 1 point, and here's where I think people get a little bit confused, and I had to figure out the best way to explain this to people because it is a little hard to wrap your head around. So next, you get 1 point for the decision to obtain old records and or obtain history from someone other than the patient. So what does that look like? Okay, so maybe the patient comes into the hospital, we don't have their old records, they're at the Mayo Clinic, and the provider documents, I am requesting the old records from the Mayo Clinic. That's the decision to get the old records, so you get that 1 point. Or the patient comes in and maybe they're intoxicated and you can't get a good history of them, but they have a roommate. So, okay, we're gonna call the patient's roommate to obtain the history. They're deciding to get that history. That's the decision to obtain that information, which is different than doing the review and summarization, which you get 2 points for. So that would look like, okay, now we've got those records from the Mayo Clinic and that provider took that extra time to read over them and do a summary. So a summary is more than just, I got them. It's more than copying and pasting a chunk of them. It's doing a summary. So a couple of sentences of what they read. So I received the records from the Mayo Clinic and it says that the patient has a long-standing history of a couple sentences of a summary. Same thing with obtaining history from someone other than the patient. So maybe it was a nursing home patient and you go, oh my gosh, we don't have any history for this dementia patient. So you called over to talk to the nurses at the nursing home, had that conversation, and then documented that conversation. So I personally spoke to the nursing home staff, the nurses there, and they said, you had a discussion with someone else. Or you obtained history from someone other than the patient and did the review and summarization. So maybe you had to contact the patient's family. You called the patient's mother and got a lot of history from them, spent that time having that conversation, documented it, and said, okay, I had an extensive conversation with the patient's mother about their past history and a couple of sentences of a review and summary. Or you called up the patient's specialist, a review and summary of another discussion with a healthcare provider. So you maybe called up their cardiologist, spent that time with the cardiologist having that conversation, documented it, a review and summary. I discussed the case with the patient's cardiologist and we agreed upon That's where you get 2 points, where you do the review and the summarization. Now, next, you also get 2 points if you do an independent visualization of the image or tracing or specimen itself, not simply review of report. And I think this is where providers sometimes get confused because they think, oh, if I just dump in the lab or the copy and paste of what the x-ray was, that counts. And it doesn't. So in order to get credit for reviewing the report, you have to say that you reviewed the report. Where you get the 2 points though, and this I think is a bit of a nuance on how you have to document it, is when it says review of an imaging, that is when the provider is actually taking the image, pulling it up, looking at the image, not just the report of what the other provider's interpretation of this image may have been, but actually looking at the image themselves and going, oh, okay, here's what I think. I took this extra time to look at this image myself and analyze it. So if the provider is looking at that chest x-ray, they should document, I personally reviewed the chest x-ray image and, agree that it was consistent with COVID or what have you. The next is our table of risk, and there's a lot going on in this table of risk, so I'm not going to go over everything. But some of the key things that you can kind of pull out is when you're looking at your table of risk, there's minimal, low, moderate, and high risk. Some of the things that are minimal are like those colds, patients coming in with insect bites, and you're telling them maybe to go home and rest and gargle, sleep it off, chicken soup, what have you. Low is more if you're having 2 or more self-limited problems, 1 stable chronic illness, an acute uncomplicated illness or injury, and maybe you're giving them over-the-counter drugs or occupational therapy or a minor surgery and there's no risk factors. So those minor surgeries are the 10-day surgeries or 0-day surgeries. Now, a moderate is more of our patients that have 2 or more stable chronic illnesses, or they've got 1 chronic illness with a mild exacerbation, and that's a key thing there. Moderate is a chronic illness with a mild exacerbation. It goes into high if it's a severe exacerbation. An acute illness with systemic symptoms Could be moderate or an acute complicated illness or injury with a brief loss of consciousness. That would be things where we're potentially ordering minor surgery and there are risk factors, or major surgery without risk factors. Prescription drug management, and be careful with prescription drug management because that can vary. My jurisdiction actually says that simply refilling a medication counts as prescription drug management, but that does not follow suit for all Medicare administrative contractor areas. So our high, those are the chronic patients with the severe exacerbation, severe COPD exacerbation. We have to give them major surgery and they've got risk factors. They've got sudden numbness and tingling, like they've lost sensation in part of their face or their hands, or they're having a stroke or a heart attack, seizures, potential high risk of suicide. They're going to potentially lose a limb. So high risk stuff. Or maybe there's a decision for DNR, de-escalating care, because there's just a poor prognosis for that patient. One of the scenarios I like to give providers, particularly in my primary care settings, is, if you have a patient that's coming in and they're going, oh my God, my eyes, my ears, my throat, I've been coughing and sneezing and sniffling and I don't feel good and I have fever and, I'm not doing so well. Yeah, new problem, no additional workup likely. We're probably not going to order a lot of stuff for them, so we get 3 points. But if that provider says, go home, rest, take some Robitussin, you'll be fine, it's just a cold. So we've got more of a low level risk, probably not ordering a lot of data, but we have those 3 points there for the new problem, no workup. Probably going to be more of a 99213 for an established patient, assuming you've got a history or examination of any kind of, decent bulk. However, patient comes in, same symptoms, I don't feel good, I'm achy and sneezy and coffee and so forth. And the provider says, you know what? Probably need something prescription strength for this. So I'm going to order you some steroids, Tylenol with codeine, whatever. And they get that script. That bumps us up to a moderate risk. So now that we've got the moderate risk and still new problem, no additional workup, 3 points, probably going to be more of a 99214, an established patient level 4 visit, because now we've bumped up that medical decision making level. So again, not necessarily always 100% going to be a level 4, but you're halfway there. So if you did any kind of decent history or an examination, you're going to meet a level 4 service. I always like to think of the table of risk as a great jumping off point when you're trying to figure out your level of service. However, medical decision making is more than just risk. Technically, if you have a patient that comes in with a new problem, you're doing additional workup, you're having a lot of discussions with other providers, getting history, ordering labs, ordering x-rays, stuff in the medicine section, you can still get a high medical decision making, even though the risk level might be a little bit lower, because you only need to hit 2 of the 3 in that category. So just because the patient isn't super high risk doesn't mean that that provider had a lot of thought process going in, that they didn't have a lot of conditions that they had to think about, comorbidities or progression, or have to think about treatment options, or spend all that time looking at different labs or x-rays or ordering them or following up or having those discussions. That's still a lot of work that goes into working up that medical decision-making process for that case, even though it might not necessarily be a super high imminent risk. So I'm going to try and throw up the table over here, and let's take a look. It says for your final result of medical decision-making complexity, you draw a line down any column with 2 or 3 circles to identify the type of decision-making. Otherwise, you go second from the left. So like I said, you can have a patient where you're doing a lot of data and you're managing a lot of diagnoses and hit a high medical decision making, even though the risk didn't, because you have 2 circles in that column. I love medical decision making, and I'm so glad that we're now moving forward with making that the key component for our office visits starting in January 1st of 2021. In the next video, I'm going to discuss time and how that can impact your level of service. And then we're going to do putting it all together, all those key components and how we put them together to pick our level of service. And we're going to look at a couple of case examples. So I hope you like this video. Hey, leave me a comment below. What do you think about these 2021 E&M changes that are coming? Do you think it's going to be better for providers, that they'll be able to have a better picture of what level of service they're going to be selecting for those office and outpatient services? Are you doing anything interesting to help train your providers? And make sure you give it a big thumbs up, this video, if it really was helpful for you. I really do hope it was. And if you haven't already, make sure you subscribe, hit that notification bell so you never miss another episode. I will see you in the next episode, and until then, just keep on coding on.